Good afternoon. This is Danny Para from the Integrated Care Resource Center, or ICRC. Thank you all for joining us today for this Working with Medicare webinar, using D-SNPs to integrate care for dually eligible individuals, as part of our ICRC's curriculum developed to assist states in better working with Medicare. Before we get started, I'd like to quickly go over a few logistics. For those of you joining by phone, you can view the slides with us by logging into Zoom. You can find those directions in the appointment for today's webinar. To eliminate background noise, phone lines are being muted during today's presentation. You can submit questions via Zoom at any point during the webinar using the Q&A icon at the bottom of your screen. There will be no unmuting of the phone lines at the end of the presentation for Q&A, but we do encourage you to use the Q&A window since our presenters are eager to answer questions you may have. If we don't get a chance to answer your question on today's webinar, we can follow up with you afterwards. As you leave the webinar today, we'll have a short evaluation to gather feedback about this webinar in the Working with Medicare series as a whole. We hope that you'll take the time to complete the survey. As usual, we'll be recording this call, so you can revisit today's presentation or share the recording with colleagues who are unable to join. Today's webinar is part of a series on working with Medicare. This series was designed for state Medicaid staff who are new to state contracting with dual eligible special needs plans, or D-SNPs, and how these contracts can be used to advance the integration of Medicare and Medicaid for dually eligible individuals. While these webinars are primarily aimed at a state audience, they're also useful for a broader audience. However, the health plan staff and providers in our audience may want to visit our sister organization, Resources for Integrated Care, which develops and disseminates technical assistance tools for those groups based on successful innovations in care models. The series includes webinars on 4 topics that are repeated annually. We heard feedback from previous webinars that we were presenting too much information in these webinars and moving a bit too quickly. In response, we're trying something a bit new here, that we're taking the material that we usually present in one webinar and dividing it into 2. Earlier this week, we hosted a webinar as an intro to D-SNPs and the basics of D-SNP contracting. And today's second webinar will include a slightly deeper dive into how states can use D-SNPs to integrate care for dually eligible individuals. Again, both webinars will be recorded and posted on the ICRC website. During today's webinar, we'll cover ways that states can use their SMAC to advance state integration, state contracting and policy approaches that can be used to promote integration, as well as having a presentation from Maine state staff on their use of D-SNP contracting. We also included an appendix with some additional resources, and we'll also hold some time at the end for additional questions that you might have. Today's webinar will feature 3 ICRC staff, Erin Weir-Lochmani, Danielle Chominski, and Nancy Archibald, as well as Paul Saucier, Maine Department of Health and Human Services. Before we get started, I wanted to go through some high-level takeaways from our webinar on Monday that focused on the basics of D-SNPs and D-SNP contracting. I'm going to be running through these quickly, but the recording of this webinar will be posted. So as we went over on Monday, D-SNPs must have a SMAC that includes at least certain federal minimums, as well as any other requirements imposed by the state. The states are not required to contract with D-SNPs and have the authority to deny potential D-SNP contracts. States can require beyond what is federally required in their SMACs. And the schedule that D-SNPs enter and leave states is based on the Medicare contracting schedule, which can be different than state Medicaid schedules. We also went over some basics of the new contracting requirements that are in place in 2021. All D-SNPs must meet the new requirements for 2021, either through becoming a designated as a HIDE-SNP or FIDE-SNP, or through meeting the information sharing requirements for a designated group of high-risk enrollees. The overall goal of these requirements are to improve the coordination of services during care transitions. Also, there is a level of flexibility for states to design their own approach to their requirements that aligns with their individual state needs, populations, and infrastructure. And states can modify their processes regarding these requirements based on any lessons that they might learn during implementation in 2021. Again, that was an extremely high-level, quick overview of what we covered during Monday's webinar, and the slides and recording for this section will be posted. I'll now turn things over to Erin to get us started with the rest of this webinar.
Thank you, Danny. As Danny noted in Monday's webinar on the basics of D-SNP contracting, we described the minimum requirements that all states must include in their contracts with D-SNPs. But beyond those minimum requirements, states can incorporate a variety of provisions into their D-SNP state Medicaid agency contracts, or SMACs, to advance coordination and integration of Medicare and Medicaid benefits for D-SNP enrollees. And today, we're going to be discussing some examples of those beyond the basics provisions that states can use. Next slide. So the D-SNP contracting requirements and strategies that I will discuss in today's webinar fall into three general areas. First, requirements related to care coordination. Second, requirements related to enrollee communications and marketing materials. And third, requirements related to D-SNP sharing of certain data and reports with the state. Next slide. The first strategy that states can use to improve integration within D-SNP care coordination is to use their contracts with D-SNPs to integrate Medicaid requirements into the D-SNP's model of care. All Medicare Advantage special needs plans, including D-SNPs, must have a model of care that describes how the D-SNP will meet the specific needs of its dually eligible enrollees. That model of care must be approved by the National Committee for Quality Assurance, and all models of care must include specific elements, including descriptions of how the plan will assess beneficiary needs, how the plan will develop individualized care plans and establish integrated care teams, and how the plan will coordinate care for their members, including during care transitions from one setting to another. Requiring D-SNPs to integrate certain Medicaid requirements into these models of care promotes integration of Medicare and Medicaid services for D-SNP enrollees. It also requires the D-SNP to describe in detail how it will improve coordination of those Medicare and Medicaid benefits. And it establishes a framework and guidelines for D-SNP staff about how they're expected to operationalize that coordination at the enrollee level. It's important to note that D-SNP models of care are written at the contract level, and that a single Medicare Advantage contract could contain multiple D-SNPs operating in multiple states, potentially alongside other non-D-SNP Medicare Advantage plans as well. So states should communicate with their D-SNPs to understand the kinds of requirements that might be most feasible to integrate into the model of care more immediately, and what kinds of things might require more incremental change over time. Next slide. So a few examples of Medicaid-related requirements that states might consider requiring D-SNPs to include in their models of care include the 4 ideas that we've shared on this slide, which are described in detail in a tip sheet that ICRC published for states on incorporating Medicaid requirements into D-SNP models of care. And we've provided a link to that tip sheet in the resources section at the end of today's slide deck, along with several other resources for states related to D-SNP contracting. So first, states may wish to consider requiring D-SNPs to incorporate information about state Medicaid programs and requirements, including programs that deliver long-term services and supports, into trainings that the D-SNPs provide for their care coordination staff to ensure that those staff are well educated about the state's Medicaid benefits and services in order to make sure that they're able to assist D-SNP enrollees in accessing and using the Medicaid services for which they qualify. Secondly, states may require D-SNPs to integrate information about Medicaid services or state care plan elements or services to support social determinants of health into the individualized care plans that the D-SNP develops for each of its members. Third, states may require D-SNPs to communicate information about Medicaid services, particularly LTSS services, to primary care providers or other members of the integrated care team. And finally, states may require D-SNPs to coordinate delivery of LTSS or other important Medicaid services during discharge from a hospital or a skilled nursing facility, or during other transitions from one care setting to another. Next slide. In addition to requiring D-SNPs to incorporate certain Medicaid-related provisions into the D-SNPs model of care, states may also require D-SNPs to submit a copy of that model of care to the state so that the state can confirm that the description of the D-SNPs eligible enrollee population is accurate and aligns with the state's Medicaid eligibility requirements. Reviewing the model of care also enables the state to identify any potential inconsistencies between the processes that are described in that document and the state's contractual requirements for the D-SNP. And the state, thirdly, can also identify other areas within the model of care where additional state-specific information might be helpful or necessary. Next slide. So in addition to requiring D-SNPs to integrate Medicaid information into the model of care, states also may want to consider incorporating other state-specific care coordination requirements into their contracts with D-SNPs. Based on what ICRC has seen states attempt in this area thus far, we've noticed three important takeaways. First, states that are interested in requiring D-SNPs to abide by certain state-specific care coordination requirements will typically need to balance the need for enough prescriptiveness in those requirements to establish clear minimum standards with a need to ensure that plans also have enough flexibility to respond creatively to their enrollees' individual needs. And while health plans generally prefer flexibility rather than prescriptive language, certain other stakeholders, for example, beneficiary advocates or healthcare providers, might desire more clear expectations for plans. So states have to really work to sort of balance all of those interests. Second, state care coordination requirements for D-SNPs have typically emphasized the importance of person-centered planning and focused on plans' responses to their individual enrollee needs, goals, and preferences. Successful person-centered care models are typically based on the D-SNP's ability to build relationships between care coordinators and members, to engage members to identify their goals and preferences, and to support and empower their members to actually achieve those goals. Finally, ICRC has found that states typically provide detailed specifications on particular care coordination elements in those D-SNP contracts. And we're going to discuss some of those specific elements on the next slide. Some of the specific elements of enrollee care coordination that tend to be more fully defined in states' contracts with D-SNPs include integrated health risk assessments, family and caregiver involvement, managing care transitions between hospitals, nursing facilities, and community settings, addressing social determinants of health, and using care coordination information technology, data, and reporting to share information with all of the parties that would be involved in coordinating a member's care. Examples of requirements that states have used to drive integration of health risk assessments, for example, include requiring use of state Medicaid assessment tools during the D-SNP health risk assessment to assess enrollees' level of care needs and LTSS eligibility. Some states have also required D-SNPs to conduct health risk assessments face-to-face for certain high-risk enrollee populations, or they've required the D-SNP to share health risk assessment or care plan data with the enrollee's primary care provider or other key Medicaid service delivery entities. Some states have also required certain elements to be included in enrollee care plans, while others have specified requirements for inclusion of certain Medicaid providers or family caregivers in the assessment process and/or in the integrated care team. States may also require D-SNP care coordinators to coordinate with Medicaid entities during care transitions or to address social determinants of health as part of the care planning process. Finally, some states have required D-SNPs and corresponding Medicaid managed care plans to maintain health information systems that meet particular standards, including standards for sharing care management or service utilization data between the D-SNP and the Medicaid plan for care coordination purposes. Next slide. The third strategy that states can use in their contracts with D-SNPs to promote integration of Medicare and Medicaid benefits is to ensure that Medicaid-related information in D-SNP marketing and communication materials is accurate and simple to enable beneficiaries to more easily navigate the benefits for which they qualify. To do this, states may wish to require D-SNPs to submit certain communications or marketing materials for state review prior to use, so that the state can review the accuracy and the clarity of the Medicaid information presented in those materials. Alternatively, some states have provided guidelines or template language and require D-SNPs to incorporate that language into their enrollee materials. In addition to ensuring accuracy and clarity in presentation of Medicaid information, template language about Medicaid benefits and systems can also help to ensure consistency in messaging across multiple D-SNPs operating in the same state. In a few minutes, Danielle will talk in a little more detail about aligned and exclusively aligned enrollment in D-SNPs, but I wanted to also point out here that states that have D-SNPs that operate with exclusively aligned enrollment, meaning the state limits enrollment in the D-SNP to only individuals who also receive their Medicaid benefits through the D-SNP's parent company. Those states can actually work with the CMS Medicare Medicaid Coordination Office to develop fully integrated versions of certain materials like the D-SNP Evidence of Coverage or Annual Notice of Change or Summary of Benefits documents, so that Medicare and Medicaid information can be presented collectively and clearly. ICRC has provided information on creating an integrated summary of benefits document in another tip sheet that we published in 2018. And that tip sheet is also included in the resources section at the end of today's slide deck. Next slide. The final strategy that I'll talk about today is requiring D-SNPs to share data or reports with the state to facilitate state oversight of D-SNP performance and beneficiary experience of care. ICRC has worked with several states that require their D-SNPs to submit a variety of types of data and reports for state oversight purposes. For example, states may require D-SNPs to submit encounter data and/or Part D prescription drug event data to the state. This helps the state obtain and review a full picture of Medicare and Medicaid service utilization for D-SNP enrollees in order to identify areas for improvement in care coordination, cost reduction, or quality of care. States may also require D-SNPs to submit to the state data or reports on the plan's performance on certain quality measures or their progress on Medicare chronic care improvement projects. Finally, states may require D-SNPs to submit financial statements or service cost information, which the state can then use in developing capitated rates for coverage of Medicaid services, as well as for validation of encounter data that comes from the D-SNP as well. Next slide. I know that I just covered quite a bit of detail, so before we transition to Danielle, I just wanted to take a minute to highlight the key takeaways from my presentation today. First, states should be aware that they can require D-SNPs to incorporate Medicaid information into the D-SNP model of care. And they can also require D-SNPs to integrate Medicaid standards and benefits into the D-SNP's care coordination practices, such as health risk assessments, care plans, integrated care teams, and data sharing. Second, states can require D-SNPs to submit certain materials for state review, or they can require D-SNPs to use standard template language issued by the state to ensure that information about Medicaid benefits and processes is accurate and clear in those beneficiary materials. Finally, states can require D-SNPs to send certain data or reports to the state to facilitate state rate setting, monitoring, and oversight of D-SNP performance and integration of Medicare and Medicaid benefits. For other examples of state D-SNP contract provisions that go beyond the minimum requirements, you can also see the 2016 technical assistance brief that ICRC published on D-SNP contracting, and that's included in the resources section at the end of today's slide deck also. And now I'll turn things over to Danielle to talk about state approaches to promoting aligned enrollment in D-SNPs.
Great, thanks, Erin. So now I'll go over some of the state contracting and policy approaches that are available to states that can promote integrated care and aligned enrollment between D-SNPs and Medicaid managed care plans. Next slide, please. So what do we mean by aligned enrollment? Aligned enrollment is when someone is enrolled in a D-SNP and a Medicaid managed care plan that are owned by the same parent company. And therefore, the beneficiary is getting all or most of their Medicare and Medicaid benefits through that same company. And these are called affiliated plans. So if you look at the graphic on the right, if someone is enrolled in Company A's D-SNP and Company A's Medicaid managed care plan, they would be considered aligned. However, if someone is enrolled in Company A's D-SNP but enrolled in Company B's Medicaid managed care plan, they would be considered not aligned. And aligned enrollment has many benefits since it allows beneficiaries to receive all or most of their Medicare and Medicaid benefits through one company. And because of that, they can receive better care coordination. Next slide, please. So exclusively aligned enrollment goes a bit further. Exclusively aligned enrollment is when the state limits D-SNP enrollment to only individuals who receive Medicaid benefits from the D-SNP's parent company. So if you look at the graphic on the right, exclusively aligned enrollment only allows enrollees in Company A's Medicaid managed care plan to be enrolled in Company A's D-SNP. Someone who is enrolled in Company B's Medicaid managed care plan cannot enroll in Company A's D-SNP. Because exclusively aligned D-SNP enrollees receive all of their Medicare and Medicaid benefits through the same parent company, the D-SNP is incentivized to coordinate all of the enrollees' benefits, regardless of whether they are covered by Medicare or Medicaid. Exclusively aligned enrollment also facilitates streamlined payment of Medicare cost sharing, coordination of Medicare and Medicaid benefits, integration of beneficiary materials, and unified appeals and grievances for FIDE and HIDE SNPs. However, it is important to note that dually eligible individuals will still have the option to choose to switch from a D-SNP to a different Medicare plan or to fee-for-service Medicare, which would result in that person no longer having aligned Medicare and Medicaid coverage. Next slide, please. So in addition to the minimum D-SNP requirements that were discussed in the 101 webinar, states can include specific policies and requirements into their D-SNP contracts to drive greater integrated care for dually eligible individuals by promoting aligned enrollment between the D-SNPs and their affiliated Medicaid managed care plans. Contracting strategies that promote aligned enrollment include limiting D-SNP enrollment to full benefit dually eligible individuals, or FBDEs, selectively contracting with D-SNPs that also offer Medicaid managed care in the same service areas, limiting D-SNP enrollment to the D-SNPs affiliated Medicaid managed care enrollees, making capitated payments directly to D-SNPs to cover their Medicaid benefits, limiting D-SNP marketing and conducting outreach to eligible individuals about the benefits of integrated care, and using Medicare and Medicaid enrollment mechanisms to facilitate alignment wherever possible. And I'll go over each of these in more detail in the next few slides. But keep in mind that these options depend on the landscape in each state. And some of these policies are only possible if the state has Medicaid managed care for dually eligible individuals. Next slide, please. So as I mentioned, states can use their D-SNP contracts to limit D-SNP enrollment in order to promote aligned enrollment with Medicaid managed care plans. And one way to do this is by only allowing full benefit dually eligible individuals, or FBDEs, to enroll in a D-SNP. And this makes it easier for D-SNPs to offer full Medicare and Medicaid benefits in one plan benefit package that's the same for all of the enrollees in that plan. And because partial benefit dually eligible individuals do not have access to all Medicaid benefits, allowing partial and full benefit dually eligible individuals in the same plan can make care coordination more complicated and prevents uniformity and simplicity in benefits and cost sharing. And states that want to continue offering D-SNPs to partial benefit dually eligible individuals can require that their D-SNPs create separate plan benefit packages for full and partial benefit dually eligible individuals. So at the bottom of the slide in the green boxes gives an example of how that could work. So for example, let's say contract number H1234 can offer one plan ID for full benefit dually eligible individuals, and then a separate plan ID within that same contract for QIMBY only or for all partial benefit dually eligible individuals. And just one thing to note here, the state examples listed on this slide and on the following slides are just examples and not a comprehensive list of all of the states currently using or considering to use these approaches. Next slide, please. So another policy that states can use to promote aligned enrollment is by influencing the D-SNP market participation through what is called selective contracting. States can require that their Medicaid managed care plans offer an affiliated D-SNP in the same service areas as their Medicaid managed care. And states can also choose to only contract with D-SNPs whose parent organization also operates a Medicaid managed care contract with that state. And states can choose to use both of these policies as well, and a number of states currently use one or both of these strategies to create an environment for aligned enrollment in their state. Next slide, please. So one way states can promote exclusively aligned enrollment, which I talked about a bit earlier, is by only allowing dually eligible individuals to enroll in a D-SNP if they're also enrolled to receive Medicaid benefits through that same parent company. So for example, if a dually eligible individual is enrolled in Company A's Medicaid managed care plan and they want to enroll in a D-SNP, they can only enroll in Company A's D-SNP and not any other D-SNP. This kind of requirement can initially result in fewer D-SNP enrollees, but it is a way to ensure that all D-SNP enrollees have fully integrated coverage. But because dually eligible individuals can always make changes to their Medicare coverage, the only way to ensure exclusively aligned enrollment is by implementing this kind of restriction through the state's D-SNP contract. Next slide, please. So states also have the option to pay a capitated rate directly to the D-SNPs to cover some or all of the beneficiaries' Medicaid benefits.
and that's called D-SNP direct capitation. And this can range from the state paying the D-SNP to just cover Medicare cost sharing, to covering Medicaid wraparound benefits, to also covering behavioral health and or long-term services and supports as well. And this way, the beneficiary receives all of their Medicare and at least some of their Medicaid benefits through one company. And this strategy is a good option, particularly for states that do not currently have Medicaid managed care for dually eligible individuals, although other states may implement this strategy as well. Next slide, please. States can also promote aligned enrollment by putting in marketing requirements into their D-SNP contracts. So for example, states can require their D-SNPs to only market their D-SNPs to dually eligible individuals that are already enrolled in their affiliated Medicaid managed care plans. States can also conduct outreach to dually eligible individuals in their state to help them better understand the benefits of aligned enrollment and how they can enroll in affiliated plans. States may also want to engage and train their state enrollment counselors to make sure that they understand the beneficiary's integrated care options and that they're explaining the integrated care options clearly to beneficiaries. It's important to note that SHIP counselor volunteers and aging and disability resource center staff and others are typically obligated to provide unbiased enrollment assistance. So these agencies are not usually able to promote integrated options or conduct marketing campaigns, but it is a good idea to make sure that these counselors are well informed and understand the options available to dually eligible individuals in their state so that they can clearly explain those options to eligible beneficiaries. Next slide, please. So another way states can promote aligned enrollment is through what is called default enrollment. And default enrollment is when a beneficiary in a Medicaid managed care plan is automatically enrolled in the affiliated D-SNP when they become Medicare eligible. So for example, if you look at the diagram, a beneficiary who is currently enrolled in Medicaid managed care company A and then becomes Medicare eligible, they would automatically be enrolled in company A's D-SNP, and therefore their Medicaid managed care and their D-SNP coverage would be aligned. Beneficiaries do have the choice to opt out of D-SNP default enrollment and make a change to their Medicare coverage. They can choose to switch D-SNPs, enroll in a regular Medicare Advantage plan, or go into fee-for-service Medicare. And if a beneficiary does choose a different option for their Medicare benefits, then they would be unaligned. States can also allow or require their D-SNPs to obtain approval from CMS to be able to conduct default enrollment if their D-SNP's parent company also operates a Medicaid managed care plan in the same service areas as the D-SNP, and if they meet other CMS requirements. We included a list on this slide and a couple of the states that are currently allowing default enrollment, although there are other D-SNPs in other states that are in the process of obtaining approval as well. And if you're interested in learning more about default enrollment, ICRC has a lot of resources available to help states understand and implement default enrollment, and those are listed in the green box on the right. Next slide, please. The states can use other enrollment mechanisms to promote aligned enrollment as well. On the Medicare side, states can allow passive enrollment from one integrated D-SNP to another if an integrated D-SNP is leaving the market. So for example, if an integrated FI-D-SNP is terminating their contract in a state, their current enrollees could be passively enrolled into another FI-D-SNP in the area. For plans to accept passive enrollment, the state and CMS must first approve its use, and the plans must meet certain requirements, although no states have used this mechanism so far. Another enrollment mechanism states can use is called Medicaid automatic assignment. States can automatically assign D-SNP enrollees to the affiliated Medicaid managed care plan owned by that same company. States can do this automatic assignment when the beneficiary first becomes Medicaid eligible, or they can do it on a regular basis, such as during Medicaid open enrollment. However, beneficiaries can still choose to manually select a different Medicaid managed care plan during those enrollment periods, and then therefore they would be unaligned. Next slide, please. So what are the key takeaways that you should remember about promoting aligned enrollment? First, aligned enrollment leads to better integration of Medicare and Medicaid benefits because all or most services are provided through one company. Second, states have several contracting and policy options that can promote aligned enrollment for their dually eligible population. And third, these strategies really depend on the current Medicaid landscape. States with existing Medicaid managed care programs, for example, may want to pursue different strategies than states in which dually eligible individuals receive benefits through a fee-for-service system. And just remember, states do not need to implement all of these strategies all at once. And many states take a more measured and incremental approach to promoting aligned enrollment. Many states with integrated D-SNP models have built their models over time and in collaboration with the D-SNPs operating in their state. ICRC has several resources in the appendix of this slide deck, as well as on the ICRC website, that can help states identify which strategies may be best suited for them and their landscape. States can also reach out to ICRC staff directly for one-on-one technical assistance for any of these strategies. And with that, I'll turn it over to Nancy to introduce our state speaker.
Terrific, thanks Danielle. So next up, we're going to hear from Paul Saucier, who is the Director of the Office of Aging and Disability Services within Maine's Department of Health and Human Services. And he's going to talk a little bit about how Maine is working with its D-SNPs to advance coordinated care for dually eligible individuals. Paul?
Thank you, Nancy. I've started in this position in 2019, came in as part of a new administration. And one of the things that we wanted to do was look at how we could improve coordination for dually eligible people in Maine. And for lots of reasons that I'll get into a little bit later, we have decided to start with a very incremental approach, as Danielle was referencing, has to do with our infrastructure, what we have here on the ground in Maine, and so on. We worked with the stakeholder group last year, and we started looking at several of the strategies that have been mentioned today, and where we ended up for the upcoming calendar year was to focus on improving our D-SNP agreement, and really to start the relationship building that we think is critical to achieving integration over time, because although you know, we tend to focus a lot on the policies and mechanisms that we can use to promote integration. It actually, in my view, comes down to the relationships that are built out there in the community. We will go to the next slide, please. So in looking at the 2021 D-SNP agreement, we wanted to achieve two things. One was to meet the new federal requirements around coordination and integration. And then, as I said, start the process of relationship building. Maine was one of those states that, you know, had put the basic federal requirements in place years ago with its D-SNP agreement and had never really reviewed it or looked at it. And really, apart from occasionally interfacing with the D-SNPs to renew contracts annually or every other year, had not been interacting with the D-SNPs at all. So that's what we intend to change as a first step in our, what I think will be a long journey toward integrated care here in Maine. So we did require D-SNPs in the new agreement to submit notifications within 24 hours. And we chose to have that apply to all hospital and nursing facility admissions, discharges, and transfers. We're asked ourselves what we would possibly do at the state with that information. You know, I think the basic premise behind this federal requirement is that that information gets to the people who need it to act upon it in real time. And if it was going to come to the state first, we didn't have infrastructure to push it back out, et cetera. And so we decided to use our health information exchange, which is pretty robust in Maine, and we've delegated or designated the health information exchange to be the entity that's going to receive that information. They already have a notification service built into the HIE, and so once a admission, discharge, or transfer is entered into the system, it can automatically be pushed out to all of the other providers who interact with that patient. So we think that that's going to be both good. It will improve the flow of information, and it will use infrastructure that's already there. And it will certainly get to people quicker than it would have had we had to build a system ourselves at the state. So we also really wanted to start the process of relationship building with our long-term services and supports sector. We have 2 service coordination agencies in Maine that administer our home and community-based services waiver programs, and also our state-funded LTSS programs for older people and people with physical disabilities. And so we really wanted them to be in the mix. And so we've required the D-SNPs to enter into MOUs with our 2 service coordination agencies. You know, on this issue of how prescriptive to be, we chose not to be very prescriptive at all here. The whole point of the requirement is to require the parties to talk to one another, enter into an agreement. And so we've told them that they need to figure out what they're going to share for information, how they're going to share it, and then how they're going to coordinate for members that they have in common. They have asked us for templates, and we've provided them, but again, we've been very clear that the agreement can be whatever they think will be useful, because to some extent this is an experiment for us, and we know it's something we can refine later. We also, in our agreement, envision an interface of the D-SNPs with our departmental case coordination unit. The CCU is an entity, a structure that exists within our main care program, which is what we call our Medicaid program, for complex cases, people who are stuck in hospitals, people who are, cycling through the system. They might have criminal justice involvement and so on. We have not in the past interfaced with D-SNPs on those cases at all, and so we envision doing that going forward. This whole process was very new to the D-SNPs and to us, because, as I said, the state had never really interacted with the D-SNPs much, except where they had to do the basic business transaction of getting the annual agreement in place. And so we held several meetings with them in the past year to go over the requirements that we were considering, get their input, and bring the health information exchange into the conversation. We brought our area agencies into the conversation, and of course our service coordination agencies. We have told the D-SNPs that we want to have at least quarterly meetings in this coming calendar year, and those will be partly educational for all of us. And so we've asked them what topics they're interested in learning more about from the LTSS sector, from the department, and so on. And we have some questions that we're going to ask them to present on. So again, the theme here being we want to develop a relationship that we can then build on in the future as we think about what our next steps are going to be on integrated care. Next slide. Just a little bit more on the mechanics of how the information sharing is going to work through the Health Information Exchange. All of the hospitals in Maine already participate, so that's easy. And they'll all be sending their information directly to the exchange. Only some of our nursing facilities participate. They tend to be the bigger chains that have more infrastructure around electronic health record and so on, and that tend to value the information that you can get from the HIE. We have lots of individual nursing homes that are not hooked up to the information exchange, and so a lot of the discussions with the D-SNPs this year has been around how to get that done efficiently. And how to get it done cost effectively. There is a charge to an initial fee to hook up to the Health Information Exchange and get the interface in place. The D-SNPs agreed to share that cost because obviously many nursing facilities are in more than one network. And so that was a good breakthrough that we had. Some of the nursing facilities are going to take longer. It's going to take us longer to get them directly hooked up to the Health Information Exchange. And so we structured this as a 2-year contract for this coming year. If the nursing facilities themselves cannot make the notification, they'll make it to the D-SNP, and the D-SNP will then in turn pass it on to the Health InfoNet, our Health Information Exchange, with the expectation that by January of 22, the D-SNPs and HIE and nursing facilities will have worked on getting all of the nursing facilities hooked up directly. You can see in the lower left there that we have, in addition to the hospitals and nursing homes, we have really good participation of primary care in the Health Information Exchange. So the likelihood is that the primary care physician of a person in a D-SNP is already participating in Health InfoNet and will now have information about nursing facility discharges, for example. We have some behavioral health participation. That's an area that we are going to keep working on, and some nursing facilities. Service coordination agencies have not been participating in the past. And again, as part of this package that we put together this year, they are being connected to Health InfoNet. And so now they too will know about these discharges, transfers, and admissions, which is particularly useful because, of course, they coordinate the home care for people that are receiving home care. So they'll know about the transitions in real time as well. Next slide. So just kind of backing into why we ended up where we did, the main landscape is, first of all, entirely fee-for-service. There is no Medicaid managed care here at all. And so although we are definitely looking at potential managed care options for the future, it was not something we could jump into this year. And it will really depend on other conversations going on within our Medicaid program, you know, whether that's where we end up or not. We do have the 2 service coordination agencies that do all of our coordination for waiver and state-funded HCBS. I realize that in many states, there are multiple SCAs, and so that's an advantage we have in terms of trying to improve the HCBS coordination with D-SNPs. We have fewer parties to work with and can focus some energy on there, so it makes sense for us to do that. Despite not being a Medicaid managed care state, we have as much Medicare Advantage activity here as any state does, about 35% penetration. We have 4 D-SNPs with 2 more coming online on January 1st, and we have growing enrollment here 17,000 people, which I know for many states is a small number, but we only have 100,000 duals total in the state of Maine. So it is an area definitely worth focusing on for us in terms of improving coordination. I mentioned that we had also had a meeting to introduce the D-SNPs to our area agencies on aging. The area agencies on aging have been doing their own work to try to interface more efficiently with Medicare Advantage. They've formed a joint venture through which they can do a single contract with a statewide D-SNP that will cover the services of all 5 AAAs if that's what's desired. And so we are going to continue to encourage D-SNPs to consider AAAs when they're looking at social determinants kinds of services like Meals on Wheels and healthy aging sorts of interventions. That's where we are in Maine. That's why we decided to take an incremental approach and use the opportunity really that was presented in the new federal requirements for the D-SNP contracts to take what we think is a pretty significant step forward. So next slide. And so to summarize, with our new D-SNP agreement, we're creating an expectation of more active engagement to strengthen the relationship, first of all, between us and the D-SNPs. And when I say us, by the way, I'm the director of the Aging and Disability Agency, and we oversee the waiver programs. We have done this collaboratively with MaineCare, which is our Medicaid agency. We're working very closely together on this. And that's really important. So, you know, we're trying as hard as we can to have this feel like one relationship to the D-SNPs, which I think makes sense to them, doesn't give them mixed messages and so on. We also want the D-SNPs to begin really relationships with those key LTSS entities that I mentioned. We've already achieved that with our planning phase, and now as we go into the first year of operationalizing the agreement with the SCAs, we'll see what that yields. And then this also further expands our health information exchange in Maine and really helps it reach to LTSS and to social determinants kinds of services, which is definitely on the HIE's radar to begin with. And so it seems like a win all around. So that's what we chose to do in Maine.
Great. Thank you, Paul. I think that was just such a great example of a state that, you know, really had not had a lot of thought on the D-SNP contracting before, took the opportunity this year because of the new federal requirements to open up its SMAC and really start to think about taking some steps. I want to make sure that we have time for questions. So I'm actually not going to have, I was going to do a few remarks, but I think I'm going to forego that. So please type your questions into the Q&A box, and I'll turn it back over to Danny to moderate that Q&A.
Great. Thank you, Nancy. And thank you to all of our presenters. That was really thorough and informational. You all did a great job. So we're going to move into this Q&A portion here. So again, continue to add any questions that you might have to the Q&A box that you'll find on the bottom of your screen here. So I have a question first that I'm going to hit over to Danielle. The question is, what is the incentive for the plan to be exclusively aligned, or is it just based on the state requirement?
Sure, yeah, that's a really good question. First, so exclusively aligned enrollment is a state requirement that some states currently require. So the plans wouldn't become exclusively aligned on their own without that state requirement. So there's a number of reasons why exclusively aligned enrollment is desirable to D-SNPs, but basically exclusively aligned enrollment means that it's a single entity that's covering all of the Medicare and the Medicaid benefits for those plan members. So it makes the plan benefits simpler and easier for the beneficiaries and the providers to navigate. And it also makes it easier for the plan to administer the benefits and provide care coordination, since all of their D-SNP members are also in their affiliated Medicaid managed care plan. And it can also be easier to streamline the payment processes to providers as well. I hope that answers your question.
That was great. Thank you, Danielle. I have another question here that I'm going to pass to Erin. So are mid-year changes to SMACs with D-SNPs allowable? For example, if a state wanted to add requirements around material submissions, et cetera.
Yes, so the short answer to that is yes, states can make mid-year changes to those state Medicaid agency contracts with D-SNPs. The state will just want to make sure that, you know, once they execute that updated contract or the contract amendment, that the D-SNP also communicates that updated SMAC to CMS, since the D-SNP does file those SMACs with CMS every year as well. So they'll want to share the updated one. I will also mention that, you know, there have been states that know, for example, just an example of what I talked about with like data sharing, for example. There have been states that require their D-SNPs to submit encounter data or other data or reports to the state. And in the contract, they will say that the D-SNP needs to submit that data and that they'll need to follow the requirements described in some other guidance document. And that can also be a really helpful tool that enables the state, when there's something that they know is going to need to be updated regularly, to be able to put that in sort of a separate guidance document outside of the contract and then make reference to that guidance in the contract. That can sometimes be a way of getting around having to make lots of changes to SMACs once they've already been submitted.
Thank you, Erin. I think we have time for one last question here, maybe one after, but are there any potential disadvantages to exclusively aligned enrollment aside from limiting beneficiary choice?
Yeah, I can take that. So first, I just want to say something about beneficiary choice. The beneficiary always has the option to change plans on the Medicare side. So at any point, the beneficiary can switch to a Medicare Advantage plan or go into fee-for-service Medicare. So just wanted to address the choice issue. And then about the potential disadvantages, I wouldn't necessarily say they're disadvantages, but one thing to consider is that exclusively aligned enrollment means that the beneficiary needs to be enrolled in both the D-SNP and the Medicaid managed care plan. So if they disenroll from one, they also have to disenroll from the other. So that's just something to consider as well. And also and I think I mentioned this as well, is that it means that there may be less enrollees overall. It might limit the enrollment overall, because that means that the beneficiary needs to enroll in both of those plans. But for the beneficiaries that are in exclusively aligned enrollment, they're getting the fully integrated coverage. I don't know, Erin, if you have any other thoughts on that.
No, I think you covered it very well. Thank you, Danielle.
Great. I do want to be conscious of time, so I'm going to wrap things up here, but there's an opportunity at the in the survey after the webinar closes to submit any other questions that you might have that we can absolutely follow up with you on. So I want to again thank all of our presenters here today If you would like to revisit today's conversation and slides, a recording of the call and the presentation will be uploaded to the ICRC website. I urge you all to visit the website and where you can find links to past study hall calls, webinars, and briefs, and also submit TA requests. I hope that this has been valuable for all of you today. If you're logged into Zoom, again, this survey is going to appear at the close of the webinar. We look forward to reviewing any feedback that you might have for this webinar and future webinars. Thank you again to all of our presenters, our partners at CMS, and to all of you for joining us here today.